welcome to Diplomat Health Conference. I am Anna Gawel, Managing Editor of The Diplomat, and thank you so much for joining us. I want to start with a brief introduction of my own. I think we've all heard the phrase unprecedented times in unprecedented amount of times over the last year and a half, but it truly does sum up what we've all been experiencing. We're living through a once-in-a-century pandemic that has touched everyone, everywhere on the planet. The 1918 influenza pandemic was estimated to have killed 50 million people worldwide and infected about a third of the planet. Now, thankfully, coronavirus deaths have not reached those levels globally. However, according to the CDC, about 675,000 Americans died from the 1918 pandemic, a figure that is sadly not that far off from the current number of coronavirus deaths here in the US, which stands at nearly 590,000. So it's certainly a sobering reminder that despite all of our medical advances, pandemics can upend society at any time. But I think it's very important to recognize and appreciate how this pandemic has galvanized such a worldwide effort, resulting in vaccines with a speed and efficacy almost unheard of in medical history. And so I think that's an ideal place to start, since our first two panelists have really been in the trenches, so to speak, of understanding this massive vaccine effort. So I wanted to introduce our panelists. We have Apoorva Mandavilli of the New York Times, who has reported extensively on vaccinations, variants, herd immunity, workplace air quality, you name it. She's written about it over the last year. And we're also very pleased to have Dr. Bechara Choucair, the vaccination coordinator at the White House, who previously served as commissioner of the Chicago Public Health Department and chief community health officer for Kaiser Permanente. So welcome to both of you. Thank you for joining us today. And just for the audience, so that you know, Dr. Choucair led the Biden administration's campaign to administer 100 million vaccine doses in the president's first 100 days, a goal that was exceeded by 100 million shots. And today, half of all American adults have received at least one vaccine dose. So Bechara, congratulations. I mean, that's an incredibly impressive achievement. But as you know, there's no rest for the weary, especially from the media. So before we get into how you surpassed that 100-day goal and what the next target will be, I want to start with the big controversy at the moment, which is the updated CDC guidelines that fully vaccinated people no longer need to wear masks or socially distance in most situations, both indoors and outdoors, with some exceptions. The announcement was a huge hallelujah moment for much of the country, but it's also a source of concern for many people. That, of course, includes businesses who, short of demanding proof of vaccination, won't know who is and who isn't vaccinated. So theoretically, everyone can take off their masks and play in restaurants and so forth, depending on state guidelines. So, Bechara, as you're well aware, there's a significant subset of the population who refuse the vaccine specifically because they don't take this virus seriously. And these are the same people who don't take masks seriously. So, the worry is that they're getting the best of both worlds now. They don't really have the incentive to take the vaccine in order to ditch their masks. So, given that a large part of your portfolio is tackling vaccine hesitancy among different groups of people for different reasons, how are you addressing these concerns that the new guidelines are going to dissuade this particular pool of Americans from getting the shot? And how might that jeopardize your larger vaccination effort?
Well, Anna, thank you so much for having me, and Apoorva, it's great to be with you on a panel. And let me just start by saying that the most recent CDC guidance is based on science. I mean, the science is evolving. We're learning new things every day about this pandemic, about the vaccines. And that's really what drove the most recent CDC guidance. We know that fully vaccinated people can participate safely in most activities, indoors and outdoors, without wearing masks, without the need for social distancing. And this is based on the fact that we've learned about the significant decreases in the number of cases. In the last few weeks, we've seen the number of cases drop significantly. We're getting real world evidence that's showing that the vaccines work, and with studies confirming that their effectiveness is over 90%. And we're also learning that vaccines are proven to be effective against the current variants that are available in the United States. And then finally, the data is showing that vaccinated people are far less likely to spread the virus. So that's what drove the CDC guidance. And to your point, there is a concern about those folks who are still not there yet to get vaccinated. And we have to be able to continue to do everything we can to make sure that we're answering people's questions. There are a lot of people in this country who are eager to get vaccinated. They got vaccinated. There's still, I believe, a lot of people who want to get vaccinated. So we want to make sure that we're making it as easy and as convenient for people to get vaccinated. But there's still also some people, a lot of people who still have questions, and those are legitimate questions. Is the vaccine safe? Were those vaccines developed too fast? Is it safe for me to get the vaccine if I'm thinking about getting pregnant? So there are all these legitimate questions. And for this group of people, we have to be able to arm them and give them the answers to those questions so that they can feel comfortable getting vaccinated. And that's why building vaccine confidence is a big part of our work in this phase of the vaccine campaign. And we're going to continue to build on that down the line.
Okay. Now, before we get into kind of a little more specifics on that campaign and the next phase of it, so Apoorva, what are your thoughts on these CDC guidelines and also this sudden lifting of mask mandates that we're seeing in states all across the country, including our own area here in the DMV?
Well, first, let me say thank you very much for including me. This is an honor to be here. And I will say Bechara is correct in that the CDC guidance is based on science. I think that's what all of the scientists and the experts that I've spoken to have said. I think where the CDC guidance starts to go off the rails a little bit is that it came as too much of a surprise to everybody, to state and local leaders, to apparently the White House, and to a lot of people within the CDC itself. So it's not that the guidance is not science-based, and I think that part should not necessarily have come as a surprise because, as he said, the evidence has been building and we have been getting more and more data on how low the risk is for people who are vaccinated of both infection and of transmission to other people. But because the guidance was intended for individuals, it didn't come with a lot of advice for states on what to do or businesses for what to do. And so everybody was sort of interpreting it in their own way. And as you saw, some states immediately lifted their mask mandates, and Texas Governor Greg Abbott actually forbade mandates at all local levels. And then some states have been very cautious, and New Jersey is going to keep its mask mandate, for example. So it's become very much of a free-for-all. And I think the implementation piece is where the CDC needed to hold people's hands a little bit more. Mm-hmm. And as far as, the rollout of the vaccine itself, again, as he said, I think that there are a lot of different kinds of hesitancy. There are people who are just waiting to see what happens to everybody else. There are people who really want to go get vaccinated, but don't either have the time or the money or the resources to get themselves there. There are people who are very legitimately mistrustful of the healthcare establishment. And then the piece that we've talked about the most, as in the last few weeks, is the piece of people who are mistrustful of the vaccine because they don't think that COVID is a big deal. That's just 1/4 or one part of those hesitant people. So there's still a lot of room for progress to be made. And I think one thing that I'm hoping to see from the administration is more concerted efforts to reach the people who haven't yet been vaccinated.
So on that note, Bechara, as Apoorva was mentioning, people have all kinds of reasons for not getting vaccinated. There are some that are just dead set against it, and some polls have shown this could be up to 20% of the population, so obviously that's concerning. But many others are taking a wait and see approach, while others have access issues. So now you're on to the next kind of challenge here of meeting President Biden's goal of inoculating 70% of the adult population by July 4th. What are some of the strategies you've used to win over vaccine skeptics or those who are hesitant, specifically in regards to two groups? One, communities of color, which have suffered disproportionately from the virus, and two, Republicans, some 40% of whom have said they won't get the shot and may not exactly be receptive to someone from the Biden administration giving them advice. What are some of the strategies that you've planned to employ and have used that have produced success?
Right. So the way I think about this, Anna, is we are now at a phase in our campaign effort where we have administered more than 275 million shots as a country. We have more than 158 million people who have received at least one shot and more than 124 million people who are fully vaccinated in this country. So we got a lot of people who are eager to get vaccinated, who raised their hands, stood up in line, scheduled appointments at community vaccination centers. Now, to get us to the 70% of adults, and by the way, we're at 60% today of adults with at least one shot. So to get us to this next 10% of adults, it's going to take a different set of strategies. And I think about it in three big buckets. One, we have to continue to make it easier and more convenient for people to be able to have access to the vaccine. So access continues to be a big issue that we want to continue to improve all along. The second piece is really around building vaccine confidence and addressing all the different populations that have different reasons for hesitancy. And then the last piece, which is centered and it's been centered to our vaccination efforts, is focus on equity. So let me just give you a couple of examples on the strategies in each one of these buckets. On the first bucket, on making sure that we're making the vaccine access easier and more convenient, we're working a lot on making sure that you don't need appointments now to get your vaccine at most of the retail pharmacies. We're working with states to do walk-up clinics. We're trying to eliminate all kind of barriers. I think you might have heard that Uber and Lyft now are offering free rides between May 24th and July 4th for people going to and from vaccination centers to get vaccinated. We're creating tools so that people can text their zip code to GetVax, GETVAX, to be able to get the 3 locations near them where they can get vaccinated. Vacunas.gov or vaccines.gov. I mean, those are the types of strategies that we do think would make it easier for people to get vaccinated and even more convenient. Now, on the vaccine hesitancy front, we've launched an effort called COVID-19 Community Core. And we know from surveys, we know from focus groups that people trust people they know. People trust people they interact with. People want to hear from their friends, their family, their neighbors who've gotten vaccinated. So as a result of this effort, we literally have thousands and thousands of people and organizations who've signed up to be able to be our trusted messengers in the communities. And these folks who we convene regularly will have access to facts, will have access to frequently asked questions, all the tools that they need to arm them and be able to engage in these conversations to get answers to people who have questions. The second piece on the vaccine hesitancy front is really around lifting up the physicians' voices. We know from surveys that physicians are the most trusted voices when it comes to the COVID-19 vaccine. So we've been working for the last couple of months now with provider organizations like the American Academy of Family Physicians, the American Academy of Pediatrics, and the internists and the AMA and other groups to lift up the voices of the physician on multiple fronts, make sure they are out and about in their local media, make sure they are engaging with their own patients, picking up the phone, talking to those folks who haven't gotten vaccinated, as well as enrolling as vaccinators themselves. We have thousands of physicians who are administering vaccines right now, and we know we can get more physicians administering vaccines in their own practices. Mm-hmm. The other thing I'll add on vaccine confidence is the importance of engaging community-based organizations and faith-based organizations. And we've put out lots and lots of resources as from the American Rescue Plan that would empower these community-based organizations, faith-based organizations to be that trusted voice in the communities to be able to build vaccine confidence as well as vaccine access. So a lot of work on this front to build the vaccine confidence front. And then the last big bucket of the strategy, and I'll pause after that, is really to continue to focus on equity. And that's been at the center of our effort from day one. So a lot of our work around building up on our mobile strategy, pop-up clinics in communities that are that have been disproportionately impacted by the pandemic. A lot of the effort with the community-based organization, faith-based organization to address the equity issues, the resources that are going directly to those communities to make sure that they are building vaccine confidence, they are improving vaccine access, the work with community health centers that serve 2/3 of their patients are people of color, the direct access to rural health clinic and making sure that vaccine is getting into rural communities. So a lot of the on-the-ground work that's really critical to be able to make sure that we continue to keep equity at the center of our work has been part of this next phase of the campaign. So that's a long answer, tons of strategies, but it's truly about the ground game at this point. It is about going zip code by zip code, census tract by census tract. It's all about the micro planning.
Well, thank you. And I wanted to actually do a quick follow-up on that, since you mentioned the role of physicians. And I know that will be a key part of the strategy, national and locally. The logistical challenges, though, it's not that easy to just, here's the vaccine to a regular doctor's office. Shipments tend to be in bulk. Obviously, many, especially rural doctors' offices, are small, so that kind of raises the issue of whether there'll be wastage, whether they have the storage requirements, and you've got the patchwork of states and counties who are more, some are very connected to the physicians' offices and others are not very connected. So you deal a lot with logistics, supply chain issues. How are you planning to overcome some of these challenges in reaching all kinds of the various physicians and providers?
Well, you bring up a set of barriers that you're absolutely right. And we're working through all of those right now. I had the opportunity to visit with 2 private practices in Maryland last week, and I got a chance to talk to both physicians who are running these small practices in Maryland, and they brought up those same exact issues, and they were able to figure out how to navigate them and still be able to vaccinate hundreds and hundreds of their patients through this effort. So a couple of issues I'll bring up. The tray size is an important challenge. As you know, the Pfizer trays come in 1,170 doses. So if you're a small practice, it will take you a long time to get through 1,170 doses. There's also the storage and handling of the vaccine. When you puncture a Moderna vial, it can last now for 24 hours instead of 12 hours if it's unpunctured. If it's punctured, it's only going to last for 12 hours. So you have to figure out how to get 10 doses in those 12-hour window. The wastage issue does come up, and we've been working on providing some guidance to providers around the wastage. As a country, our wastage of the vaccine, of the COVID-19 vaccine, is less than 0.3%. That's truly very, very low. And that shows how seriously we've taken as a country the importance of getting every dose into people's arms. And yet, when you look at multi-dose vials, your average wastage is about 5%. So we're doing so much better. So we've been working with providers to make sure they know that we have to continue to do everything we can to preserve and use every dose in a vial, but we don't want to do that at the expense of getting the opportunity to vaccinate someone who happens to be at a doctor's office at that point. So we're navigating a lot of these issues on the tray size. Pfizer now is working on smaller tray size. So instead of 1170, there'll be a 450 tray size and 3 boxes of 150. So again, it kind of like goes, you literally have to go barrier by barrier to try to eliminate those. The other concern that I've heard from doctors' offices is we don't have waiting room areas that are big enough to have a bunch of people waiting for the 15-minute observation. So they've been creative in figuring out where to put their waiting room chairs, borrowing space from neighbors and other folks. I mean, it's just been amazing to see how the medical community is rallying up. Those are legitimate concerns. We have to continue to figure out how to solve them. But I think the commitment and the enthusiasm from the doctors community, the provider community is just outstanding. And we know that when you have those folks who still have questions about the vaccine, irrespective of what your political affiliation is, the most important intervention we can offer you is a conversation with your doctor. So that's why this part is a significant strategy in this next phase of the campaign.
Mm-hmm. Yeah, well, lots of creativity required and coordination. Now, of course, when we're talking about President Biden's goal of 70% getting one shot, and hopefully, if needed, the second shot, we're still looking at 30% of the population not getting inoculated. And now, Apoorva, you wrote an interesting article on herd immunity and the growing consensus that we may never reach it and instead learn to live with these periodic outbreaks. But, if we're dealing with still a sizable portion of the population that is unvaccinated, there's fears that we could have, 2 Americas in essence, a good portion of the population that has to deal with these outbreaks versus the rest of the people. And then, of course, the larger concerns of variants, and again, herd immunity that could jeopardize even those who have received the vaccine. So, what do you think in terms of herd immunity? Is it doable? And, and this concept of learning to live with the virus?
I mean, as you said, I think it's looking very unlikely that we will actually ever reach herd immunity. This is something that we've talked about since the beginning of the pandemic, that this was the point at which we would start to be able to say goodbye to the virus and we could get back to normal. And what it's looking like now is that we will actually never really say fully goodbye to the virus. It'll be more like see you sometime soon. And the virus will continue to make appearances periodically in different parts of the country. And a lot of that will depend on where the vaccination rates are the lowest. So if you have particular counties, particular states where the vaccination rates are low, that's probably where you're likely to see more of the outbreaks. And that from there, the virus can actually then be transmitted to even areas where the vaccination rates were high. And you mentioned that, one of the big risks with that is that every single person that the virus infects is an opportunity for the virus to evolve further and to maybe become, turn into a variant that is either more contagious or, doesn't respond to the vaccines that we have right now as well. And we've already seen some of those variants. The variant that was in the UK and is now in the United States, has quickly become more than half of cases in most of the states in the US. And that one is more contagious. And there's another variant that was identified in South Africa that we now know that all of the vaccines we have are a little bit less effective against. And that actually brings me to a caveat that I think is very important to all of the data that we've been talking about. Almost all of the data that we have for vaccines and how effective they are and how often vaccinated people get infected, how often they transmit, almost all of that is for Pfizer and Moderna. When we start to talk about J&J and AstraZeneca, we have a lot less information. And J&J in particular has been used in the United States, and we don't have as much information on how often people who've been vaccinated with J&J might get infected. I'm sure you've all heard about the Yankee cluster. I think there's still a lot of questions about who infected whom there, and it's possible that they were all infected by an unvaccinated person, but the fact still remains that quite a few people in that team were infected, even though they were vaccinated with the J&J vaccine. So I think that is going to be a question to really watch, and it will become extremely important globally because even in the very few places where a lot of low and middle income countries, have been vaccinated, it's been with AstraZeneca or, in a few places J&J, but it'll be very important for us to know how good those vaccines are, because even if there's a variant that develops somewhere else in the world, either because people are not vaccinated at all, which is true for a lot of countries still, too many countries still, or even if they're vaccinated, they have received only AstraZeneca or J&J, and those are not as effective as the variants that may be circulating, we will see more variants come up. We are all in this together. And if there are variants that come up in Bangladesh or, Uruguay or wherever, they will show up to the United States. And so it's very important for the world and for the Biden administration to cough up more doses. The richer countries are actually sitting on a lot more doses than they need. And there was only about 0.3% of the vaccines that have gone to some of the lowest income countries. And the world really needs to do better with that. I know that the Biden administration has donated or agreed to donate 80 million doses, but the actual number that we will probably need for the world is 11 billion. So when you think about that, 80 million is really a drop in the bucket. And so that will become a huge part of the conversation, at the World Treaty Organization and, with European countries.
I mean, Apoorva, I'm glad you mentioned that point. We are on the second day, be really the focus of the panel on the global impact of COVID and talking to WHO on, as you said, coughing up more vaccines at the end of the day. Now, you also raised an excellent point about J&J that I think is often overlooked. So 2 questions, Bechara, because I know you have to leave a bit early. One, have you encountered specific worries in terms of J&J and the link to rare blood clots in your work? And then kind of a broader question. I mean, we are constantly looking ahead to the next clinical trial, to the next, booster shot and so forth. But I think it is important to look back and remember that in just 4 months, the Biden administration has orchestrated the largest and really most complex vaccination campaign in U.S. history. You were tasked with making sure that 100-day pledge was fulfilled. So, I would love to just get your thoughts on, I know it's a big question, how did you do it? I mean, what were some of your biggest successes that helped you exceed that goal? But also, what lessons did you learn from the missteps along the way?
Thank you, Anna. I have to say, I mean, I am in awe as to how this country came together to be able to get us to where we got when it comes to vaccinations so quickly and so effectively. I got to interface with governors. I talked to local leaders. I saw the private sector, the not-for-profit sector, all coming together to be able to get us here. I think from day one, our goal was pretty clear. We wanted to get as many doses into as many people's arms as quickly and as equitably as possible. That's really has been the North Star for us from day one. And to get there, we really focused on 3 big things. How do we work on supply? And to your point, that was the number one issue that we were dealing with when we got into office, how to increase supply. How do we make sure we have enough vaccinators across the country? And the third piece was, how do we create more places for people to get vaccinated? And that's been truly kind of our focus from day one. On the supply front, we've done a lot of work there. And I just remember in the very first week that we were in office, we had 8.6 million doses of vaccine that we were sending out across the country. And last week we had 28 million. So we got that's more than 3 times more. And that's a lot of the work with Pfizer, with Moderna, who both actually exceeded their, expedited their commitment for their contracts. J&J that was able to get the first 20 million doses early on in the delivery process. So there's a lot of work on supply that made it easier. So now everybody 12 years and up in this country is eligible for getting a vaccine. The other big focus was really around making sure we have enough vaccinators. And I know, I mean, this was new for us to be able to get people in this country, everybody vaccinated as quickly as possible, or every 16 and up at that time. So we made sure that we've we've amended the PrEP Act so that pharmacists, senior medical students, senior nursing students, optometrists, podiatrists, and other professionals could become vaccinators. And we've deployed federal personnel across the country to support vaccination efforts. Actually, more than 9,000 federal personnel were deployed across the country, including more than 5,000 active duty military folks who were supporting the vaccination efforts. We've reimbursed more than 2,300 National Guard to be part of this. It truly was about bringing the country together. I think the third part of the strategy was really around making sure that we have more and more places for people to get vaccinated. And FEMA did a fantastic job in supporting states, tribes, and territories across the country and standing up community vaccination centers. We've deployed more than $4.8 billion to 58 states, tribes, and territories across the country to stand up community vaccination centers, provide resources, whether it's logistics support, staff support, or just financial resources to do that. FEMA stood up their own 39 our own 39 community vaccination centers in zip codes that have high social vulnerability index and provided more than 5.5 million vaccinations through those channels. The community health centers engaging with people living in disadvantaged communities or people living in poverty. This is probably one of my favorite programs that made vaccines available to those communities through trusted community partners and their community health centers. And over 70% of doses administered through this federal program have gone to people of color. The federal pharmacy program, when we started, there was no pharmacies, there was no federal pharmacy program. And now we have 21 chains, almost 40,000 stores across the country that are delivering the vaccines. So it was a monumental effort. We've learned a lot along the way. It was challenging, it was hard, but we knew that we have to get it and we have to get it right. And we have to continue to learn and evolve and respond to the needs and the communities to be able to get to where we got today. And, we got up on day 100 on day 92 with 200 million shots already administered. We got up on day 93 and we have to continue to work equally as hard because we know we still have a lot of people that we need to get vaccinated.
You're on mute.
Technology. Bechara, thank you. Before we let you go, real quickly, we have questions, and it's interesting. They're all centering around booster shots, and so we just wanted to ask, is your office, is the planning underway to distribute boosters already?
Well, let me just start by saying, and I know Apoorva will probably weigh in on that a little bit later, but from my perspective, we will obviously have to wait for the FDA and the CDC to kind of review where the science is, make the recommendations, and we are exploring a range of scenarios. So we will be ready should there be a need for a booster. At this point, we'll have to defer to the CDC and the FDA on this process. Once there is a recommendation or a decision, we'll be ready to execute. We are planning for a range of case scenarios.
Okay. Well, I'm sure you will be very, very busy in the months to come. And so on that note, I know you have to leave us a bit early. The White House calls, literally. So thank you so much, Bechara, for being with us today and for your insights. We really appreciate it.
Thank you so much, Anna, for inviting me, and Apoorva. It was great being with you on the panel. Thank you so much.
Too.
So now, Apoorva, though we have you for a bit, so I wanted to follow up on this concept here of booster shots, but tie into what you were saying earlier about the need to vaccinate the world and how this has to be a global effort. I mean, you have the U.S. already talking about booster shots, and you have, in one of your stories, mentioned only 0.3% of vaccine doses administered globally have gone to the 29 poorest countries, which are home to 9% of the world's population. So these statistics are very grim and disheartening. Do you realistically think, I mean, the instinct, of course, is you inoculate your own people. I mean, Biden would face a huge backlash if he didn't do that. How realistic do you think it is that we're now going to transition into this next phase to provide this enormous amount of vaccines that the world needs?
I mean, as you heard, I think the Biden administration is gearing up to roll out booster shots if and when the CDC and the FDA give the green light. And I think it's a very good chance that they will. Moderna has been testing a booster, both just giving another dose of the vaccine they already have, as well as a booster that's specifically designed for the variant that is from South Africa. The one that I mentioned earlier is a little less sensitive to vaccines. And so they designed a vaccine candidate that is very specifically intended to combat that variant. And one or the other of those is going to end up being the booster. And Pfizer has similar plans. And already the data are looking pretty good. So I'm sure that the company will plan to apply for FDA approval at some point. And the Biden administration really has not given a very straight answer on what their long-term plan is for helping the world. So they put, through their support behind this idea of a patent waiver, but which is, essentially means that the companies would not go after any companies in low and middle income countries that try to make the same vaccines. But without, these big manufacturers showing those smaller companies how to make their vaccines, that the patent waiver is basically ineffective. And so we're in a situation now where we've got the richer countries looking at booster shots, but also vaccinating their kids, who we know are at pretty low risk. And while there are healthcare workers in a majority of the countries of the world who don't have vaccines, and there are hundreds of doctors dying all over the world as they are trying to treat patients. And as you know, in the United States, those were the first groups that we vaccinated. So they haven't even started there. Meanwhile, we're talking about vaccinating 5-year-olds. And don't get me wrong, I'm a mother, I have 2 kids, and I will take my son to get vaccinated. He just turned 12. But I also have family in India, and I'm very aware of the fact that, we are able to vaccinate people here who are at very low risk, while there are almost no people elsewhere who have been protected. And so that's a very tough question. And the Pfizers and Modernas of the world have said that they will be able to make enough to supply the entire world. But as long as the richer countries have another reason, boosters, they want the vaccines to be extremely effective against variants, we are not going to see, I don't think, a big amount of donation that will really help the rest of the world.
Mm-hmm. And of course, I mean, I know the Biden administration and wealthier countries have come under a lot of criticism for that. And unfortunately, it might take variants here really wreaking havoc in the U.S. for the message to come through that if the world isn't vaccinated, then the problem will never go away. Another aspect, as you had mentioned earlier, talking about I want to go back to the CDC's new guidelines. And when we talk about criticism, we know that the CDC has come under quite a bit of it from the get-go here, for being too strict on the recommendations and now possibly being far too lax or just a lot of conflicting, confusing messaging. And I know the New York Times has written a lot about, the fact that early on for a long time, it was emphasized that roughly 10% of transmissions occurred outdoors when really the figure looks to be well below 1%. And, so while we've been focusing so much on the outdoor transmission, the CDC was not really playing up the threat indoors. And specifically, the fact that the virus can be airborne and linger in the air and be spread by the air. So, you could be 6 feet away or 60 feet away. There is still this danger. So, the CDC is under a lot of constraints. Do you think some of the criticism, has been justified or unwarranted? And what kind of changes, we're already hearing about some shakeups, do you see at the agency moving forward?
Yeah, so let's take the indoor piece first. And there's no question that not just the CDC, but the World Health Organization was entirely too slow to move on that. I wrote about the World Health Organization being resistant to the idea of airborne transport last summer. And it's taken them all of this time. It was just in April, at the end of April, that they finally used the word aerosol on their website. So they have had this very medicalized idea of what airborne transport means. And part of that is because this is how doctors, infectious disease physicians, think about it. And the WHO and the CDC are both full of people who are experts in that. So they think about, when you say airborne, that it implies the virus can go any amount of distance, anywhere, outdoors or indoors. And so they really shied away from using that word, and they had all these other ways of describing it that I don't think really made the point to people. Outdoor, safe; indoor, not. That's all we really needed to know. And we needed to know, as you said, that indoors, even if you're 6 feet away, 16 feet away, it doesn't matter. If it's a crowded room with poor ventilation, you are still at risk. And that's a big part of the conversation that was missing, when we talked about indoor dining, for example, where people are maskless and, in a crowded room with a lot of other people. And I think they would have saved more lives if they had been very clear about what the risks were and about what the needs for ventilation were. And they didn't do that until really recently. And even now there's some confusion. On the outdoor transmission, I do think that the evidence points to it being minimal and possibly, very, very little. There's only a couple of studies, really, one from Italy and one from China, that have implicated outdoor transmission. However, to be fair to the CDC, it is a public health agency and it's their job to be extremely conservative. Let's imagine that, because we don't have a lot of data, it actually does end up being closer to 10%, and we don't know this yet. We would have been extremely angry with the CDC for saying that the risk is minimal when it wasn't. So, the CDC and the agencies like that are in kind of this position where there's always going to be somebody who says you're too conservative, and there's always going to be somebody who says you're not being conservative enough. And with this latest guidance as well, I think that has been part of the problem. In fact, Paul Sachs, who's an infectious disease physician at Harvard, has this blog, and he was writing saying, well, half the country seems mad at the CDC for being too conservative, and half the country seems to think that they were just, rushing this. So they probably did the right thing. So it's sort of like that, they kind of do have to find a middle ground. And you mentioned that there are some changes at the CDC, but I don't necessarily think that's a bad thing either. There have been 2 high-profile exits. Nancy Messonnier, who was the head of the Respiratory Diseases Division at the CDC and was very heavily involved in the vaccine response. She's the one who was famous for warning the country and then was sidelined and silenced by the Trump administration. And then Anne Schuchat, who's the deputy director, and she's staying on till the summer. But without going into a lot of details, I will say those were 2 separate instances and 2 separate women who are leaving for very different reasons. And I think that we do have to be somewhat careful at not holding Dr. Walensky, who is a woman, to a higher standard than we have held previous male directors, because there are high-profile exits with every new CDC director. So I think there's a much sharper focus on her, partly because she's a woman, partly because this is a pandemic, partly because we all seem to care what the CDC is doing much more than we ever have. Maybe not infectious disease reporters like me, but the average person. So I think the spotlight is very bright and very intense, and I'm not sure there's a lot of nefarious goings on with the CDC exits. I think that is perfectly understandable. But could the CDC be better in communicating what it's doing? I think absolutely. The last week has shown us that.
Yeah. Well, and as you said, they're under an unenviable position. I think that's a great point that you raised of Rochelle Walensky being a woman and how that does have an impact on people's perceptions. And just in general, average people, know more about the CDC than they ever did. So there are changes, major changes that have been happening. What, just to wrap up, you've covered so much of this over the last year. Are you optimistic that we are taking the lessons that we've learned to heart to better prepare for, unfortunately, the next pandemic at some point? Or are you concerned that once this pandemic subsides, that the attention, the resources, the manpower will subside along with it?
Well, I think for the United States, it really depends where you are. If in the United States, the Biden administration has actually put in a lot of money into public health. In the new budget request, there are massive amounts of money allocated to ramp up public health, to train public health personnel. And I think if we can keep that up, it's always hard to maintain improvements in public health. It's getting started is easy. But if we keep that up, I think the United States might be in a decent position to fight the next pandemic. But as we've seen, pandemics are global, and it will not matter if the United States is completely ready, but other parts of the world are not. And we've seen this over and over. We have learned this lesson so many times. We learned this lesson with HIV and a lot of the, the fights over the patent issues. This is exactly what we saw after HIV drugs became very common in the United States and saved a lot of lives, but in the rest of the world, people didn't have access to them. So millions of people were still dying elsewhere. And that's exactly what we're seeing happen with the vaccines now. We've also seen something playing out right now, I think, that the world has seen with TB, where TB was once everywhere and people died from it all over the world. And then TB became a disease of the poor. You mentioned earlier, it's going to be two Americas. It's going to be two worlds. It's going to be the countries that can afford to protect their people and the countries that cannot. And just like TB is now a disease that is mainly in parts of Africa and parts of Asia, I think any new virus that comes up eventually, once it has, had its day, will become like TB, a disease of the poor, a disease that's, situated in just certain parts of the world. And unless we as a world can figure out how to not have that happen, I think the course of any pandemic is going to be exactly like that.
Right. And this is, we could talk forever about this, and this is something we will be discussing tomorrow on the next COVID panel. We have WHO, CDC, Cigna, the ambassador of New Zealand, specifically talking about how hopefully perhaps we can keep that from happening, even though I know that the odds are stacked up against it. But lots of people who are working to ensure that there is global equity to this vaccine. So Apoorva, I want to thank you so much for joining us, for all of your insights. I wanted to let the audience know we will be transitioning over to our next panel, where we're moving into cardiology. I think we're so focused on the pandemic, but there's lots of other health issues happening and lots of other exciting innovations that we'll be talking about in the next panel in a few minutes. And now, in the meantime, I just wanted to remind folks that on your left-hand side, you can go in anytime to the expo booths, and you can kind of visit our sponsors and get more information there. You can also click into the networking part of this, and you will be randomly matched with a participant, and you will have 3 minutes to network, just like you would in person. We're doing our best in this virtual environment, and it's a really great opportunity to meet people. You, as I said, you will have 3 minutes. You can click connect to share each other's information and profile, just like you would a business card. And if you want to extend the 3 minutes, all you have to do is both participants just have to click on the extend button. So you can do that at any time throughout the conference. But I hope you will stick around and check out in a few minutes our next panel on cardiology. And in the meantime, Apoorva, again, thank you so much. Apoorva, you can read all of the latest of what's to come in the New York Times. And thank you. Appreciate you joining us today.
Thanks for having me.